I'd like to appreciate Frontiers in Health Services for according us the opportunity to make a presentation on our paper, but also most importantly to thank the editors and everyone who was involved in the review process. It was quite long, but very necessary to ensure that we have a piece that is indeed up to acceptable standards. My name is Periken Tunkole, and I work for the African Alliance as a project strategist for the Ports to Arms intervention, the foundation on which this particular article was sort of developed. And I'll share with you today some of the findings that you might have already read on the this particular piece from Ports to Arms, Reimagining Demand Creation for the African Context. So with regards to the topic that we had written on, it was basically on reimagining demand creation for the African context, drawing on lessons from past pandemics such as the experience with the HIV pandemic, but also more recently the COVID-19 pandemic. As you might have seen on the Frontiers in Health Services site, this particular article was published on the 19th of December. And of course, it draws on the work of the Ports to Arms intervention, funded by a grant from the South African Medical Research Council and the Department of Science and Innovation. And of course, I'll shed more light on what Ports to Arms looked like on the ground when we tested and piloted the intervention from inception and indeed last year. So with regards to the authors who were involved, some of whom are on the call today, of course, every author contributed equally to this work and shares first authorship. From the African Alliance, we have myself. My name is Periken Tunkole, and I'm based in Lusaka, Zambia. Francesca Alice is based in Durban, South Africa, and also works with the African Alliance. Anna Matenda Wafa, based in Harare, Zimbabwe. Comrade Tian Johnson, also joining us on the call, who is founder and strategist of the African Alliance, and of course, who is based in Nairobi. From the Pandemic Emergency Readiness Lab, McGill University, Montreal, Canada, we have Alex, who's also on the call today, as well as Lily Young. And of course, we did go through a very interesting writing process for this particular piece to bring it all together to finalization. With regards to a bit of a background about the African Alliance, we were established in 2012. And of course, as the African Alliance, we seek to advance rights-based critical developmental programming to address the needs of underserved communities across the African continent. And we do this by working collectively to ensure that affected communities are informed about their rights, but they also have access to dignified healthcare and agency, and access to hold duty bearers to account for non-realization of their rights. The African Alliance's research engagements are grounded in transformative feminist participatory action research approaches, and these approaches seek to ensure that engagements with communities include a change agenda to address stigma, discrimination, and inequalities at whatever level that they happen. The Ports to Arms intervention, from which we drew key findings for this particular, publication, is one of the flagship projects under the African Alliance. And in very, very basic terms, it is a community-led public health accountability mechanism, and it contributes to our organization strategy by documenting and amplifying underserved and marginalized community members' lived experiences during and post-pandemics. We do this by highlighting their invisibility and specific access challenges in order to improve future public health emergency preparedness. And so at a much more advanced and involved stage, the Ports to Arms intervention, while it was initially intended for the COVID-19 pandemic, has evolved to track pandemic prevention, preparedness, and response at a much broader scale across the African continent through key advocacy as well as movement building strategies. With regards to the way that we had defined demand creation in this particular article, we said that demand creation is increasing of and demand for health products or services among a particular target audience through social and behavioral change communication and social marketing techniques. While there's a marketing component, the intention is not to increase demand by all means necessary using whatever methods, but to ensure that we understand fully what the intention, what the aspirations, what the needs are for communities, and channel all efforts towards increasing the appetite and demand in that regard. With regards to looking at the COVID-19 pandemic in retrospect, which I think the previous speaker had touched on, quite well, we drew key lessons in this particular article from the COVID-19 pandemic in terms of key barriers to distribution and key barriers to access in terms of the COVID-19 vaccine rollout across the African continent. We realized quite early at the inception of the Ports to Arms intervention that despite millions of COVID-19 vaccines coming in, there was a significant historical legacy to contend with, compounded by underbundled and indeed under-resourced public health systems. While there was a lot of effort at global level to ensure equitable vaccine access for the global south, we did see that there were gaps on the ground with regards to vaccine hesitancy, which is fueled in some cases that we found by mis and disinformation. This is covered extensively in our other article that was published by the Frontiers in Health on how misinformation fuels vaccine hesitancy within the African continent. It is fundamentally immoral to position communities to demand a product before it is provided and before they have received adequate information to make a decision, about its use. There was a myth that was going around during the COVID-19 pandemic that the majority of Africans are against the COVID-19 vaccines or vaccines in general, which was really untrue, because when we probed further, we saw that there were a number of barriers to distribution, barriers to access that prevented the vaccine from moving from ports by the time they arrive at airports, at seaports, to the time they make it into communities and eventually on someone's arm. There were a lot of, sort of systematic limitations that prevented the journey of a vaccine from moving from a port to someone's arm, and hence the name of the intervention, Ports to Arms. We realized that communities need accurate and regularly updated information in accessible formats, steady and accessible vaccine supply, and meaningful engagement to build trust between communities and governments, between communities and vaccine distributors as well. When the COVID-19 pandemic hit, it was also compounded by already existing health system challenges around access to public health in general. So in this particular article, we also were able to probe how or what would a community-led vaccination rollout look like that puts communities at the center and also puts into considerations their needs, their aspirations, and their specific contextual challenges. This particular successful community-led vaccine rollout would be one that would ensure that vaccines not only reach ports, but are equitably distributed in a way that recognizes and can respond to the realities already strained public health systems, significant disease burdens, geographically dispersed communities, and inequitable access to public goods and services. And so one of the challenges, as you observe from the vaccine rollout for COVID-19, is that, and I think as part of the post-COVID efforts by African governments within the healthcare system, is to sort of integrate the COVID-19 vaccination rollout program within the broader health system within the different countries. A community-led approach that is able to identify the specific barriers, like I mentioned, to a proposed response. And in this case, a successful vaccination program will identify and promote enablers to access. Ports to Arms as an intervention, like I shared before, uses a community-led monitoring approach to monitor and document barriers and enablers on the ground to COVID-19 vaccine access and uptake. And I think we did a lot of work in that regard during the COVID-19 pandemic. It would be very unwise of us to move forward with lessons from COVID-19 without acknowledging some of the lessons we had already learned from the HIV pandemic response as well. Case in point, within the South African context, I think what we learned was that any successful African vaccination demand creation strategy must be informed by lessons and mistakes from the recent past. Too often, awareness is raised for a new commodity or product without putting into consideration lessons from the past pandemic, which then perpetuate these issues for future pandemics. New HIV medications in South Africa resulted in the creation of community-led demand, only to result in a lack of supply when communities ultimately tried to access these products. And so it would be very strange to build demand for a particular product, and then the supply, the limitations in distribution do not allow communities to be able to have access to those particular products. So reimagining demand creation on a rights-based approach, a lack of community ownership during the COVID-19 pandemic was highly evident with regards to the vaccine rollout across the African continent. Communities were, put aside; they were not actively engaged. Large international bodies with no real contextual experience or understanding made assumptive decisions about local vaccine delivery. While there was a lot of work being done to advocate for equitable vaccine access for the Global South, there was little understanding on what the realities were, what the challenges were, and what prevented vaccines from moving from ports to arms. When vaccines were available, many historical and ongoing realities resulted in limited uptake and vaccine hesitancy, like I mentioned earlier, in many instances fueled by mis and disinformation, corruption in a few instances in South Africa, in Zambia, and some other African countries during the pandemic, the COVID-19 pandemic, that resulted in mismanagement of resources meant to ensure that communities have access to vaccines. As a result, effective demand creation must differ from traditional demand creation in the marketing sense, which often sees communities as a passive actor to traditional social marketing techniques. A rights-based approach would definitely encourage and engage active participation from communities and recognize the need to fully realize their right to health. And so it is very important to ensure that at every stage, there's active and meaningful engagement with communities without making assumptions on whether they will accept the vaccines or not. In terms of key best practices that we highlighted in this article, we said that a community-led approach to demand creation, grounded in human rights, would first carefully listen to and consider the concerns and needs of community members in its design and implementation. And it is not just at the point of implementation that we should engage communities, but from the time, the ideation, the design, up to implementation, we should be able to have a system in place to engage communities in order for us to ensure that we, increase demand and appetite for vaccines across the African continent and globally. As part of the best practices, this particular approach does not seek to increase vaccination by all means necessary, but rather puts agency strengthening and recognition of basic human rights at its center, and not isolating one issue and sort of generalizing it as the one need that the communities have, but putting into consideration other aspects, socioeconomic aspects as well that hinder access to vaccines. To increase demand, we've said that communities must regain ownership over the COVID-19 vaccination rollout, and of course, general public response, general pandemic response as well. And so if communities are not fully engaged, if communities are not taking ownership of the vaccination rollout, it is likely that we'll get high levels of hesitancy and low levels of interest in accessing these vaccines. So as part of our conclusion in this particular piece, we underscored the fact that focused and locally tailored interventions are vital to ensure an equitable, rights-based response to the next pandemic or health emergency. What is needed is a constant effort to support communities in taking control over all aspects of their health. When communities lead the response, the local agency is strengthened, and the trust that is built creates the demand. Only when demand is created within a human rights framework will vaccines be efficiently and equitably transported from ports to arms. that is our brief summary of the paper that we had submitted to the Frontiers in Health. Happy to hand over to Sarah for the discussion, and happy to take on questions. And as we have some of the authors on this call, if they would like to jump in and make any clarification that may arise. Over. Thank you.
Thank you very much for the presentation, which was also spot on in terms of timing. I think I would like to invite now any of the co-authors to add anything that they may find pertinent before we kick off the discussion. And I also would like that in the meantime, already anybody with an interest in posing a question, so feel free to put it in the chat. And then we will be also using it. I will be using it as a guide for inviting questions from the audience. Is any author interested in making a comment? So please raise your hand. Okay. Tian Johnson, please go ahead.
Hi there, colleagues. Thanks so much for having us and giving us this platform. Just to say, apart from great job, Perry Kent, this piece of work really helped us be spectacularly agile, at a moment where the pandemic landscape was changing so rapidly. We found ourselves at a time where tools and interventions like Ports to Arms that were designed at the height of, waves of death now almost found themselves hanging. And I think it's a credit to the approach and the team, that we've since been able to apply Ports to Arms as an approach across disease areas, in cholera, in Malawi, and looking at other disease areas like HIV and Ebola. So it's just proof yet again that investments made into approaches like Ports to Arms for pandemic strengthening don't only have resonance in that particular pandemic, but can certainly reap these rewards going into the future. But thank you so much, Frontiers, for the opportunity for ourselves and the team to really showcase this really important work that we did.